One here is the CME code 10684. If you have Cloud CME, enter that code. You have 3 hours, up to 3 hours after this presentation to enter the code. If you want CME credit, please send me an email. This presentation is being brought to you by the Ethical Advisory Committee at the University of Maryland. And these various ways to contact us. We run a 24/7 committee, and I always like to tell people I realized we became a bona fide consultation service when we started getting ethics consults at 4 o'clock on Friday afternoon, so I'm expecting one in just a few hours. So this is being accredited, CME credit from the University of Maryland, and again, send me an email if you wish to enter you for CME credit. The objectives of this session is to be able to discuss ethical dilemmas in clinical practice and also explain how to use an ethical framework for solving ethical dilemmas. So, the presentation, ethical issues during the COVID-19 pandemic. This slide shows the 3 issues I like to discuss. First one will be ethics of vaccine challenge studies in healthy human volunteers. Then we'll talk about allocation guidelines for distribution of remdesivir. And I asked the question, should a social justice framework be adopted? And then lastly, we'll discuss how to balance duty to treat with a duty to family and self. So let's start off with the ethics of vaccine challenge studies in healthy human volunteers. So a little history. The first well-known challenge study was performed by Edward Jenner regarding smallpox in 1796. This was, he induced an intentional infection to protect against disease, and he inoculated an 18-year-old boy, James Phipps, with cowpox derived from a lesion on the hand of a dairymaid. And we see in this picture a very willing young boy. Well, actually, that's just one depiction. I think this picture shows the scene that most likely happened, and we'll talk about informed consent towards the end of this part of the presentation. That said, challenge trials continued on not infrequently in the history of medicine. In 1937, this investigator infected 72 volunteers via inhalation of a human influenza virus, and 20% developed disease that was mild in intensity, and the model was deemed safe and was utilized for several decades to understand immune responses to influenza and test preventative and therapeutic measures. And there have been several other types of human challenge studies, and I show the headlines of 2, one in 1999, and then the other one in 1971. However, in the early 2000s, influenza human challenge studies came to a halt. In that one study, a 21-year-old experienced myocarditis following infection with mild influenza B infection. And despite return to baseline health and despite the lack of a direct causality linking myocarditis to the influenza challenge stock, no further influenza challenge studies were conducted in the US for nearly a decade later. However, challenge studies started in the turn of the century, and I show one from 2014 regarding an influenza A human challenge model. And we see in the abstract that background, we see healthy volunteer influenza challenge models offer a unique opportunity to evaluate multiple aspects of this important virus, and the investigators continue this unique clinical research program will facilitate future studies of influenza pathogenesis. So we have these challenge trials that have been going on with several different disease types. So what I show in this slide the ethical framework that should be used to evaluate the ethics of these types of human challenge trials. And what I like to discuss the ethical requirements that includes the social value of the study, the scientific justification for using a human challenge study, need to discuss the risks to the participants, and then the validity of informed consent in such trials. So I gave out a SurveyMonkey exercise to get this group's perception of the ethics of human challenge trials, and I asked, should scientists infect healthy people with the coronavirus to develop vaccines? And the majority, 55%, said no, and about 20% said yes, and 20% were uncertain. So let's understand what are the issues with the human challenge trials. Why are so many people saying no? So, well, regarding social value, where are we today? Well, this map shows the high intensity areas where the virus is pervasive. Now, worldwide, there's been close to 400,000 deaths, and more than 6 million people have confirmation of having been infected with this virus. So to develop a vaccine obviously would be very important to stem this fatality and morbidity associated with this virus. Now, when we read about the development of vaccines, most of the discourse has been on field studies of vaccine testing. So a field study represents the traditional vaccines studies that are conducted in field conditions that are similar to future routine use. Essentially, we have a randomized controlled trial, and where participants are randomly allocated to receive either the investigational vaccine or the placebo under routine, normal field conditions. However, the sample size depends on the incidence or the burden of disease in the study population. And hence, if you have a low incidence, that means large numbers of subjects are required to estimate the vaccine efficacy. Essentially, you need people to get infected through the normal conditions in order to determine whether the vaccine has been effective. So essentially, people are talking about large phase 3 trials enrolling more than 30,000 participants. And hence, these trials will take a long time, and the concern is that time is running out. Essentially, there are practical time constraints. The mumps vaccine took 4 years, and for this pandemic, recent estimates cite at least 1 to 1.5 years for a vaccine to be developed. And essentially, A significant proportion of that time is due to the requirement to assess efficacy and safety in large-scale placebo-controlled phase 3 trials. One is thinking that one has to test multiple vaccines, and also there needs to be intensive sampling of the study participants, for example, with nasal swabs to see if they've been infected with the virus. So the concern is that this may take too long. So people are now considering the case for experiments on human volunteers to test the virus. And this article was written up in the Washington Post a few weeks ago. So essentially, instead of waiting for participants to be exposed in field trials, challenge trials short-circuit that process by exposing people deliberately to the virus. Human challenge leads to a vaccine available before the epidemic has completely passed. At least that is the reason to do the human challenge trials, is to do them, get a vaccine much sooner than one would get in a field trial. So advancing the rollout of an efficacious vaccine, even by a few months, could save thousands of lives and command enormous social value. So essentially, it may be worthwhile to move the clock back as much as possible in human challenge trials. Now, this slide shows a comparison of the time between field trials and the human vaccine trial. So in a field trial, we have phase 1, phase 2 dose finding and initial safety assessment, and then we do a large scale phase 3 trials. In human challenge trial, we have to develop the challenge system, and then we assess efficacy in controlled human challenge trials with small numbers of individuals, and then we do a large scale, short-term expanded phase 2 safety study involving about 300 participants. So that's the, so hence, let's see. So challenge trials are often substantially smaller, shorter, and less expensive than field studies, and it would enable the efficient selection of vaccine candidates for further investigation in larger studies. So now the other issue with field studies is, since we need to select an area where there is ongoing transmission, so essentially these field studies has to be precisely timed during active transmission of the virus. So public health policies in many jurisdictions might suppress transmission, and in fact, that's what we hope to. However, if we're very successful, then such field trials might be unfeasible. Hence, the burden of field trials done during COVID-19 epidemics would be concentrated where public health policies are weakest, or where people don't follow public health policies, and hence the disease incidence is highest. So where should we do these field trials? Well, one suggestion would be Sweden, which has moderately, only a moderately degree of lockdown. As virus deaths rise, Sweden sticks to low-scale lockdown. And I know we have one person on this webinar who's from Sweden, so I'm just wondering if she'll be able to volunteer her country for field studies. Alternatively, we could choose locations that choose to relax their restrictions quickly. So, for example, Florida or Georgia or some other state in which there is more relaxation of restrictions. And in fact, we see this person in the middle of the picture here, give me liberty or give me death. And I think we could volunteer her not only for a field trial, but maybe for a human challenge study. Now, alternatively, we could have pick locations unable to do social distancing, for examples in low and middle income countries. However, that would entail justice implications in a global south, and we would want to avoid exploitation. Now, the WHO has issued guidelines that these vaccine studies, especially human challenge studies, should only be conducted in centers with significant experience in designing, reviewing, and conducting human challenge studies, and is able to offer high quality care. Human challenge studies would be more ethically acceptable during inter-epidemic periods when field trials would be unfeasible because the rate of transmission would be low to the point where field trials would be unfeasible. So essentially, the scientific justification for challenge studies involves acceleration of vaccine development, selecting better vaccines because you could test the vaccines in small sample size human challenge studies. And challenge studies may be the only way to test vaccine efficacy, especially during lockdown or social distancing measures, again, when the virus is not being transmitted extensively. Also, human challenge studies could give us a lot of scientific knowledge about aspects of immunity, infection, and transmission. So, what about the risks of challenge studies? Usually, challenge studies are done in less lethal diseases like malaria, schistosomiasis, and influenza. However, COVID-19 is a dangerous disease and may be also associated with rare severe events. Now, human challenge studies, the concept is that this would be tested in adults less than 30 years. However, even in that age group, the fatality risk is about 0.007 to 0.03%. So it's not insignificant, the risks of human challenge studies. And also—
fatality risk of coronavirus is 0.007 to 0.03%.
Okay, so wait, so you're saying it's lower or higher? I can't count all those O's.
Oh, sorry, that was just me reading out loud.
Oh, you're reading from my slides.
Yes.
I see.
Sorry
Okay. Would you like to continue? Oh,
No. I was just reading, talking to myself.
I see. Okay. So sorry to interrupt, but anyway, the other major issue with risk is the need for a rescue medicine in case these healthy volunteers get ill, and one would want to have a rescue medicine available to save these patients. So now, are these unreasonable risks? So we actually ask people to take such risks for others' direct gain or for the good of society. We ask volunteer firefighters to rush into burning buildings. We ask healthcare providers to fight a pandemic that augments both their personal risks and family risks, and we'll talk more about that at the end of the hour. And also the risk of death from a living kidney donation, so essentially kidney donations from healthy individuals, is actually similar to the fatality risk that healthy volunteers would be exposed to in human challenge trials. So essentially, are these really unreasonable risks that healthy volunteers take for the good of society? Now, we could also minimize risks by enrolling healthy patients from age groups in which the risk of severe disease from infection is low. Now, we could recruit only people with an especially high baseline risk of getting exposed during or soon after the trial period. This actually is not a way to minimize the risk, but maybe we would be more justified by taking patients from who are exposed to a high baseline risk of getting infected. Also, participants would be monitored carefully following the challenge study and be afforded the best available care if needed. And also, maybe by the time vaccine candidates are being tested, maybe some therapeutics may be approved. We have remdesivir being approved. However, we all know that's not a magic bullet. Now, there are a lot of uncertainties with human challenge trials. One, what would be the actual time to complete a challenge trial? So here's a slide I showed before, and I showed you this part of the slide before, comparing field trials with human challenge studies, and was trying to make the case that human challenge studies would take less time. However, in evaluating and preparing the challenge system, that actually may take a long time. And essentially, the question is, will we save time with a human challenge study? The other uncertainties is confidence about risk estimates. Fatality risk actually may be higher, and we need to know exactly the risk factors for severe disease among young, healthy individuals, and what are the long-term risks, and are there lasting harms, and should we have a rescue therapy and when we do these trials? And lastly, there's a lot of uncertainty regarding the generalizability of the findings of human challenge trials to high-risk populations. Now, remember, these challenge studies are testing a vaccine in healthy volunteers, and so will the results be generalizable to risky populations. Also, these healthy volunteers will be exposed to a less risky viral strain which may not be equivalent to the virus strain that's out there among us. So there's a lot of uncertainties with the risk. Now, what about informed consent? There's a website, One Day Sooner, in which people have been signing up, volunteering to participate in human challenge studies. More than 28,000 people have signed up from 102 countries, and the developers of this One Day Sooner effort give the rationale that these people could actually, they could be empowered to understand more about human challenge studies to enhance their human agency. And now, another issue about informed consent is the incentive. How much should they pay? How much should they get paid in order to participate in these challenge studies? So why don't you all take 10 seconds and tell me whether you think it should be $1,000, $2,000, $4,500, or $10,000. Okay, all right, I'll give you a few seconds to vote. How much would it take for you to participate in a challenge? Okay, while you're voting, let me see, there's been, oh, so someone mentioned offering to pay for a term life insurance. Okay, that's a interesting concept. And coverage of all associated medical expenses. Right, this is the incentive to enter the study. Right, so let me end the polling and share the results. And most people say 2,000, and then 1,000, 4,500, and 10,000. Okay, so there was one website that says, want to help cure coronavirus, get paid $4,500 to get infected. So that's the going rate. So is this undue inducement? Well, a lot of people say that this concept of undue inducement doesn't really exist. And also, there's been studies showing that the mere fact of offering a large amount of money actually tells people this is a risky study. So actually, the payment helps with healthy volunteers understanding that this is not your garden variety randomized controlled trial. So where are we now? Well, I think that we're fine with the social value, informed consent. To be sure, the concern is that one would prey on vulnerable groups. However, I think that there would be a lot of safeguards against that. Scientific justification for doing human challenge trials. Again, a lot of uncertainty regarding, especially, will it actually save time, and will it actually get us the vaccine? And what about the risk? A lot of question marks about the risk. And on one hand, do we need a rescue therapy? Is it appropriate to expect healthy volunteers to participate with any risk of death? On the other hand, we, in other walks of life, we ask people to expose themselves to risks of death for the good of society. So I'll leave you with one last slide about this subject matter. In the Bloomberg opinion, eradicating COVID-19 might justify risky vaccine trials. So I'll end with some final thoughts. Challenge studies should not be considered ethically unacceptable. They may sometimes be ethically required. However, because they are ethically problematic, they should, however, be subject to especially rigorous oversight. So any vocal thoughts from our community here before we go on to the next topic? Anybody want to, Mike, do you want to add anything?
Absolutely, if I may.
Oh, yes, absolutely, please.
A few comments.
Okay.
First, I would like to speak to the social value, the informed consent, the justification, the risk very briefly. But let me say that the University of Maryland, and certainly the Center for Vaccine Development, now CVD and Global Health, has been doing challenge studies for 50 years. I did my first challenge study 50 years ago. And we have considered a variety of possible challenge models, some of which we decline. So let me say the process historically that we use that may be relevant because we are a place that has done such things. We ask the clinical severity of the natural disease. As you didn't bring in, Henry, the point that when this first publication by Nir Eyal and Peter Smith and Mark Lipschitz came out, we didn't know a lot of the complications that we now know about COVID-19, and that needs to be mentioned. We asked if it's a treatable disease. At the moment, this is not. You very well spoke to the lack of a rescue therapy. If it's not treatable, is it self-limited? This is not. What's the risk to the community? Very important question. Do we need physical containment? Do we need quarantine? Can we document the subject's baseline health, and can we assure follow-up? Now, we also asked at CVD for years, after we go through that list, we then asked, if I were age eligible, would I do the study if I'm going to give this to somebody else? That's kind of a personal, ethical question. And would I be comfortable with my family members doing the study? So with respect to what Eyal and those folks raised, many of their premises are really not correct. It's not the 4 years of a mumps vaccine, Henry, we should consider. It's how long it took to get the first licensed, what we call FAIC, Public Health Emergency of International Concern vaccine. So the FAICs that have been declared and are of relevance include the Ebola 2014 outbreak in West Africa. And in August 2014, there were 2 vaccines sitting in a bottle, 2 different types of vaccines. One had never been in people, one had been in one human being. And 10 months later, there was evidence of the safety in good numbers, of the immunogenicity, and of the efficacy of one of those vaccines, which led to, 1 year later, the ability to use that vaccine under an emergency use authorization that WHO and others gave. And in December of 2019, it was licensed. So it's the comparison is 10 months to getting to evidence that a vaccine can work in a relevant population. Knowing that this works in healthy young adults does not extrapolate to the population where the deaths are occurring. And many of these publications focus on why this has to be done to prevent all these deaths. Well, the deaths are largely occurring in the elderly and in people who have host factors, such that when they're given the same vaccine, we cannot know either their immunogenicity or the efficacy in that group whose lives we're supposed to be saving until we actually get those data. So it's kind of a false, a canard that has been put up. I've just finished 5 weeks of chairing a World Health Organization committee that's addressing what you've just covered in this half an hour. And it includes a lot of challengeologists, includes people with coronavirus expertise, et cetera, and a real spectrum that have views kind of similar to the poll you took. But what this group has done is to dissect every step that's needed to have a safe, the best that we can do model. And Henry, that includes using high-level containment in early studies. It includes identifying the viruses to make the challenge inocula. We have a list of like 40 viruses. It took a couple of weeks just to get that. It's going to take time to see if those viruses grow to a titer, even if they have been properly purified by plaque purification ×3 in qualified cells. Anyway, all of these steps take time, and the challengeologists, I'll call them, on this WHO committee, they put together a protocol and a consent form. One thing about the consent form is that if these studies are done in the United States under, let's say, NIH auspices, consent form will state, unless a pot of money is put aside, that any acute medical care needs would be taken care of. But if, perish forbid, a stroke occurred and there's a long-term deficit, the consent form says that they're on their own. And these minor details need to be grappled with. And the last thing is, this discussion takes place in a real world in which 80%, or some polls say 70% of people would be happy to have a COVID vaccine if it comes along, and 20 to 30% who don't get their kids' measles vaccine or other immunizations, and who are anti-vaccine across the board with very, very experienced vaccines that have lots of safety data. They're out there, waiting to pounce. They believe in conspiracy. What happens if, in well-meaning, even with a rescue therapy, if these things go ahead and there is a death, does that really move us faster to getting this vaccine out to the rest of the world and the United States? Or does this feed this subportion of our population, and it exists in middle income, and it's starting to get to appear in developing countries? Anyway, those are some of the points. I think this is a very, very complex one, and it's the kind of thing that there really has to be better justification in the minds of many other people to go ahead. Having said that, if there were a rescue therapy, then many of the challengeologists on this WHO committee would be comfortable. Right now, there's a lot of concern, certainly about the timeline. It's going to take a very long time to set up the model to identify a virus, to then do the first vaccine efficacy. And sorry for that long comment.
No, that was great, Mike. I'm so glad that you were able to really eloquently capsulize the major issues with this human challenge studies, and I certainly resonate with all of your concerns about the rescue medicine, the generalizability, and will we actually save time? So let the debate continue with the challenge, Jala quiz, or whatever you call them. Okay, great, thanks. To be continued. So let me rapidly go on to allocation guidelines for remdesivir, and should a social justice framework be adopted. And I'll tell you more what I mean about that in just a few minutes. We all know about the remdesivir study, and let me show you this slide. Essentially, it was a randomized trial over 1,000 people, and it showed improved time to recovery 15 days versus 11 days. Interesting, mortality was 12% versus 8%, a p-value of 0.059. So that in itself is an ethical issue. Essentially, was it ethical to stop the trial when one was so close to the p-value, significant p-value of mortality? Just yet another ethical issue to consider with these trials. But anyway, maybe I'll discuss more about that in the next session. So anyway, so the federal government rolled out its allocation, and we see the blue dots are the centers that got the drug, and the green that did not. And there was, guess what, a lot of concerns about how the federal government pushed out the allocation of remdesivir. Be that as it may, there is a shortage, and hospitals, just like San Antonio in this headline, has to confront rationing it to the patients. And so this has left hospitals with the complicated task of rationing remdesivir. So essentially, what is the most ethical way to do that? So let's explore that. Now, the guidance from the FDA is somewhat limited. It just talks about physiologic parameters, has to meet parameters for oxygen saturation, liver and kidney function, and patients have to have no known sensitivities to any of the drug's ingredients. This is the allocation system in the state of Maryland, and let me just say that well, they say try to maintain sufficient supply. That's actually a no-brainer, and essentially you could get this drug either within the confines of a clinical trial or expanded access, compassionate use, which is available for pediatric patients and pregnancy. And then outside of these two mechanisms, if you meet the physiologic criteria of oxygenation and no liver and kidney disease, then you go into either a tier 1, 2, or 3, and without complicating all this, but if there's a shortage among tier 1 patients, essentially one would resort to a lottery. So very, very simple. Now, the question is, should there be additional criteria instead of just a lottery? Well, the West Virginia hospitals are using patients according to first come, first serve. However, first come, first serve approach should be avoided because it's not random and it disadvantages those who experience barriers to access to care. Now, some states are using more restrictive criteria in order to save their limited supply of drugs. So Michigan issued guidance based on need, calling for hospitals to use doses for patients who had more severe needs, such as those on ventilators and ECMOs. In San Diego, they based it on benefit. They want patients only eligible if they had symptoms for no more than 10 days, because the thought is that remdesivir works better early on in the course of the illness. Now, there was a recent paper in JAMA, an ethical framework for allocating scarce inpatient medications for COVID-19 in the US, and they list their main ethical goals: saving lives, those with good near-term prognosis, and they also mentioned 3 other items: prioritizing essential workers, do not exacerbate disparities, but they also mentioned mitigating current health disparities. Now, concerning essential workers, here I gave you a poll, and developing allocation guidelines: should healthcare workers prioritize to get the drug? And actually, this crowd, which I'm assuming mostly from the healthcare field, was somewhat split. Only a slight preference among the people who said yes. So essential workers, who are they? Well, we essentially talk about those with instrumental value, those who are important with the infrastructure of the community's ability to respond to the pandemic. And then we also talk about this concept of reciprocity, essentially those people who are risking their lives for the good of society, and hence society should reciprocate and give them somewhat higher priority to get the drug. Let me just say, with this concept of essential workers, it's not necessarily a neutral category. Essentially, essential workers often have high status employment, and essentially it leaves out those who are unemployed and in non-essential jobs, and hence may serve as a proxy for the displaced and devalued members of society. And hence, if we pick on if we prioritize essential workers, we may exacerbate disparities. So in the interest of time, now there is the concept, do not exacerbate disparities, which means avoid discrimination. However, in the interest of time, let me go to the important topic of mitigating disparities. Now, I think we all agree we should not exacerbate disparities, but what about mitigating health disparities? Again, should we mitigate? And I thank my discussions with Doug White on this issue. So I sent out a poll and developing allocation guidelines. Should we give priority to lower socioeconomic groups who have endured health disparities? Should they be prioritized to get the group? And most people said no. So is there a case to be made to prioritize those who have endured health disparities? So for sure, there are widening disparities from COVID-19. And I mentioned this publication that was put out a few weeks ago, and for sure, there is vast differences in the death rates across the races, and we see the figures here, much higher for the Latino and African American group, and there's inequities in previous ability to access the healthcare system, and social distancing is actually a privilege in high, dense, urban, poverty-stricken areas of cities. Social distancing is actually very difficult to do. So disparities in COVID-19 case fatality rates disproportionately affect African American and Latino communities. Where does that leave us now? In terms of social justice, a quote from Larry Gostin: "A failure to act expeditiously and with equal concern for all citizens, including the poor and less powerful, predictably harms the whole community by eroding public trust and undermining social cohesion." So with this issue about social justice and the good of the community, another quote: "I am in Birmingham because injustice is here. I am cognizant of the interrelatedness of all communities and states. I cannot sit idly by in Atlanta and not be concerned about what happens in Birmingham. Injustice anywhere is a threat to justice everywhere." Essentially, Martin Luther King took care to ground his sense of justice in awareness of the interrelatedness of all communities. He recognized that inequalities are never the exclusive problem of the group they seem to most directly affect. Health is interconnected. Whenever a distinct group suffers from poor outcomes, the burden will be shared across populations in ways both subtle and overt. So essentially, what is fairness? Groups with heightened vulnerability to the disease affect the health of population as a whole. And let me just add, just out recently in the Hastings Center report, there was an article, vaccine, here's the story about vaccines again, vaccine rationing and the urgency of social justice in the COVID-19 response. This article goes on to say the case of vaccine rationing is particularly instructive. Ethical, epidemiologic, and economic reasons demand that rationing approaches give priority to groups that have been structurally and historically disadvantaged, even if this means that overall life years gained may be lower. So yet another controversy about how to ration vaccines. So let me end with another important topic: how to balance duty to treat with duty to family and self. I was asked a question by one of my colleagues: are doctors obliged to sacrifice their lives to save patients' lives? Is it part of our medical oath or code of medical ethics? Good question. So I gave you a poll. Are there circumstances in which a healthcare provider might be justified to decline his or her duty to care? And almost 80% said yes. So how do we justify that? So here are some headlines. Doctors and nurses around the world are calling in sick. Doctors threaten to quit the National Health Service over shortage of protective kits. So essentially, what are the risks? Well, the risks are not insignificant. A large proportion, of frontline healthcare workers are getting infected. Fatality rate is 0.6%, severe infections 15%, and additional burdens in the form of family members in vulnerable groups, such as elderly, which have a higher fatality rate. So let me just say that healthcare workers have a fiduciary obligation or relationship with their patients, and are obliged to take on more risk and burdens to care for the sick than the lay public. And so essentially, what is the basis of the healthcare worker obligation? Well, we consent to it when first accepting the role, and there is the concept of reciprocity between healthcare workers and society. Essentially, in our contract with society, we get a monopoly, income, and status, and hence that also serves as a foundation as to why we have an obligation to risk our lives. And now, the strength of the duty is proportional to the benefits we get from society. So the strength of the duty is greater with doctors, doctors greater than nurses, greater than social workers. However, what is the strength of the duty to treat, and how do we balance it with the duty to self and family? So essentially, the strength of the duty to treat is proportional to the likelihood of risk to self, which depends on our comorbid conditions and age. The strength of the obligation to family members that may be in our household. So children greater than parents, greater than distant family members. Also, the likelihood of harm to a family member in our household. So elderly obviously have greater harm, and the likelihood of infecting a family member. So if we live in a household in which it's difficult to social distance, then the infection rate is most likely higher. So essentially, depending on the likelihood of risk to self, as the likelihood of risk to self increases, and the strength of our relationship to families, and the likelihood of harm to family member, and the likelihood of infecting a family member, as all of this increases, our duty to self and family increases compared to the strength of the duty to treat. And all things considered, it winds up being a personal decision for sure. So this is just a quick and easy framework on how to balance duty to treat or duty to care versus duty to self and family. And so let me take a breath, and I appreciate your attendance, and let me just, if anyone wants to unmute themselves and ask a question, please feel free to do so. Right, someone is mentioning white coats for Black Lives demonstration. They're having. I'm happy to make this public service announcement. 3 p.m. today, sent by the hospital here at the University of Maryland. So to support what's happening in our society today. Any any other questions? I think
This is, hello? Can you
yes,
hear me?
yes.
Yeah, this is Norton Nelson. I'm talking from White Oak Medical Center. And we've been dealing with this issue of remdesivir, and we've been also talking about it at the Maryland Healthcare Ethics Committee Network. And one of the points that I wanted to make is that when we are talking about allocation of scarce resources or triage, you have to really maintain a bright line between withholding therapy because it's not medically effective versus withholding therapy because even though it would be effective, we don't have the capacity to provide it to everyone who would benefit. And I think those two streams have to be kept separately. It's one thing to tell someone that we're not giving remdesivir, for example, to your mother because it wouldn't work, as opposed to it would work, but we just don't have enough drugs.
Absolutely.
And I think, some of the examples of the allocation schemes that you described that different hospitals are using is really obsolete, because if you dive into the details of the NIAID study, what you discover is that even though the top line mortality benefit didn't quite reach statistical significance, it did reach statistical significance for certain subgroups. The overall mild mortality benefit was kind of submerged in the fact that some groups benefited in a major way and some groups didn't benefit at all. But so what they found was that people who were on advanced oxygen support, either high flow nasal cannula or non-invasive ventilation or mechanical ventilation or ECMO, got no benefit. The people who were early in the course of the disease, not defined in terms of time, they didn't find the 10 days more or less to be an effective discriminator. The people who either were on standard oxygen supplementation, which is a major finding, and there was a non-significant trend toward people who didn't require oxygen yet. And those groups are the ones that got a major impact, and particularly the people who were just receiving standard oxygen supplementation had a hazard ratio for mortality of 0.22, almost 80% reduction in mortality. That's huge. And what we have adopted is a framework where we will give remdesivir to every patient who walks in early enough in the course of the disease to fit into the categories where we can see benefit from the study that we have in hand. By the time they're on advanced oxygen support or they're on mechanical ventilation, we deny it, not because we have insufficient supply, but because of the lack of medical effectiveness. And that's not triage. That's not allocation of scarce resources. That's medical effectiveness. That's a standard medical paradigm.
Right. I can't agree with you more, but the fact remains we have a shortage of a drug with benefits, as you said, and if we're able to treat all, so be it. But a lot of hospitals are confronting short supplies, and they can't give it to everyone who can obtain a benefit.
Well, it depends on what you mean by can't give it to everyone. We have more than enough.
You can't give it to everyone.
We can, but that's today. Maybe 3 weeks from now we won't, and then maybe a day where we'll finally be down to our last 4 doses,
Also,
and 5 people will be in the ED.
Right. Well, some hospitals are experiencing a shortage. right now in some areas in the US. And that's why, I mean, they have allocation guidelines. University of Maryland has allocation guidelines just in case. And the issue is, what should those allocation guidelines be? At the top of the list, you want to give it to people who could benefit from it based on the randomized controlled trial. But then the question in my mind after that, one could surely resort to a lottery, which is unbiased, okay? However, the issues I brought up is that are there other groups in times of shortages, are there other groups whom we should be giving priority? And so in my mind, the two major groups are essential workers, especially healthcare workers, and two, whether we should prioritize those groups who have been exposed to systematic injustices in their access to health care. That's where the discourse should be. And as I showed you in one of my last slides, just last week, an article in the Hastings Center are bringing up the potential issue about rationing vaccines, because when we finally roll out a vaccine, in the beginning, there will be a shortage. We're not going to have 3 billion doses all at once. And we need to start having that discourse now. If it's not with remdesivir, that's great, but there will be a shortage in the beginning with the vaccine, and we need to have that discourse now. So it's not easy stuff. And Norton, I appreciate your comments.
You're welcome. Thank you.
Any other thoughts? Anybody left here? And where is the well?
Those 41 participants. There are a
Yes,
lot of people
41 are still here. Anybody want to have a question? Yeah, I am saying I think it's a healthcare worker's personal choice based on these factors. We all have our values. I think the basic foundation is that we have an obligation to risk our lives, and the strength of that obligation really depends on those factors I mentioned, and everyone needs to figure that out for themselves and discuss it with their colleagues and their what I'm trying to say, their managers or whoever you want to you need to discuss that with. Okay, all right. I think I'm gonna have this recording available. I'll send it to the people who have registered on this webinar, and I'll post it on my website. So let me thank you for your tolerance of me trying to squeeze in 3 important ethical issues in 60 minutes, but I wanted to get that out there. All right. Okay. Well, I'm gonna end the meeting, and everyone stay safe, and I hope we get out of harm's way. And I know I have a lot of colleagues from Egypt on this webinar, and I know things are still very severe. So I hope you all stay safe as well. Okay. All right. Bye, everyone.